colleagues, good morning. My talk today will discuss about grade 3 meningioma. Anaplastic meningioma are malignant rare tumors representing 1 to 3% of all meningiomas. They are more frequent in men and have a poor prognosis with a reported 5-year survival of 28 to 61%. Talking about pathology, meningiomas are the most common intracranial extraparenchymal tumor and include a large spectrum of tumors with varying histopathological features, ranging from benign tumors to atypical to more aggressive anaplastic ones. They include 3 different subtypes that could be anaplastic, rhabdoid, and papillary. The diagnosis of meningioma can be done by immunohistochemistry, since most meningiomas express EMA, progesterone receptor, and vimentin. Anaplastic meningiomas are defined if they show a markedly elevated mitotic activity, a frank malignant cytology resembling carcinoma, melanoma, or sarcoma, and if they had molecular alterations. In particular, in contrast to previous version of the classification, molecular markers are now introduced as grading criteria for selected subtypes. In the new classification, any meningioma with third promoter mutation and or a CDKN2 or B homozygous deletion is allotted to WHO grade 3 irrespective of histological criteria of anaplasia. Furthermore, 2 subtypes formerly associated with grade 3 that are rhabdoid and papillary meningioma will no longer be allotted to a specific grade based only on the subtype histology alone. For these subtypes, grading is now determined on the basis of the same criteria of atypia and anaplasia of other meningioma variants. The most frequent alteration in molecular pathology are chromosome 22 deletion and mutation of the other NF2 allele. With increasing aggressiveness and WHO grade, NF2 mutant meningiomas accumulate copy number alteration, of which deletion of chromosomal arm 1p and chromosome 10 are typically the first events, and with CDKN2 A or B deletion indicated a highly aggressive curve. In particular, oncogenic variants in the third promoter and CDK2 deletion are genetic alteration observed in less than 5% of meningioma and are more frequent in NF2 variants and in patients with a chromosome loss, a chromosome 22 loss. These alterations are associated, as said before, with a high risk of recurrence and with a dramatically shorter progression-free interval, regardless of other histological features. But what are the cases in which we have to perform a molecular assessment? Impact now, the update made, the 8th update made in August and published in August 2024, said to us that we have to perform the molecular test if we have a problem for diagnosis. For example, if we have an unresolvable differential diagnosis, and we have to perform the molecular assessment for grading additional risk assessment in features borderline between grade 1 and grade 2, when we have a brain invasive, otherwise benign meningioma, when we have a WHO grade 1 meningioma with unexpected rapid growth, when we have a grade 2, when we have a chordioid, clear cell, rhabdoid, or papillary histology, and when we have meningiomas in children and young adults or adolescents. The natural history of the disease depends on the localization of primary tumor. Anaplastic meningioma frequently occur in the convex surface of the cerebellum, parietal region, and rarely also in the spinal cord. They can be extremely invasive and destroy the surrounding bone and extracranial soft tissue. The recurrence rate is very high, being more than 90% of cases, and distant metastasis is a rare event, being present only in less than 3% of cases, being the lung the most frequent site of distant spread. For make the diagnosis, we have some radiological exams that could be the CT scan that could describe an hyperdense extraaxial well circumscribed dural base mass. But the method of choice is MRI that could show an hypo-ISO intense T1 image or an hyper-intense T2 image and showing a vivid constant enhancement. Surgery is considered the chief treatment for grade 3 meningioma, and as a rule, complete resection of the tumor together with the dural attachment should be pursued with surgery. The fundamental principle of meningioma surgery is, however, that we have to have a maximum safe resection with low morbidity and preservation of neurological function. The extent of resection is strongly associated with the probability of recurrence, and it is generally graded according with a scale that is named Simpson. However, when gross total resection is not possible, a planned subtotal resection should be undertaken to preserve neurological function. Radiosurgery has been established as an alternative therapy to surgery in well-defined cases with small tumors in elderly or in critically sick patients. Local culture of small size intracranial meningioma, less than 3 centimeters, has an outcome similar with radiosurgery in comparison to surgery. Cranial nerve function, that is the major concern for skull-base meningioma, could use a combined treatment using subtotal surgery and stereotactic radiosurgery, and this combination is increasingly used. External radiotherapy after surgery is considered a standard of care in patients with CNS WHO grade 3 meningioma and also in case of subtotal or gross total resection. Radiotherapy, furthermore, can be considered in patients unsuitable for surgery. The optimal planning is individualized and depends on size, proximity to critical structures, and prior radiotherapy treatment. This figure demonstrates what is the outcome after radiotherapy in WHO grade 3 meningioma. You can see that progression-free survival at 3 years and 5 years could be of 64 to 58%, and then survival at 3 and 5 years is of 82% and of 76%. Talking about systemic treatment, we know that several treatments has been tested in meningioma refractory to surgery and radiation therapy. However, none of them has suggested a clear clinical efficacy. Thus, to date, there is no standard therapy, no standard systemic therapy, and the inclusion of this patient in clinical trials remains the best written option. This table shows that these are the studies that have tested chemotherapy. We have studies with temozolomide, with hydroxyurea, and this is a randomized phase 2 trial conducted by IRCCS. As you can see, the there is no clear benefit demonstrated with none of these drugs. In particular, this is the phase 2 study, randomized study conducted by EURCCS, and you can see that trabectedina, in comparison to standard of care of the local standard of care, give not a difference in progression-free survival at 6 months, that is 29 in comparison to 21, and nor in overall survival, being 10 months with local treatment and 11 months with trabectedin arm. Somatostatin analogs have been used in other clinical trials in recurrent meningioma, and also in this case, all phase 2 studies with small numbers of patients, you can see a progression-free survival at 6 months that is in median 44%. Angiogenic inhibitors has been used in clinical trials, antibodies and also small molecules. And you can see also in this case phase 2 trials with small number of patients, a progression-free survival that can go to from 37% until 69%, but small patients. Some studies have studied target agents, and you can see here, for example, imatinib with a phase 2 study, or for example, immunotherapy, nivolumab and pembrolizumab. And also in this case, you can see that the results are more or less the same. In conclusion, grade 3 meningiomas are characterized by rapid growth, early recurrence, risk of systemic metastasis, and particular molecular features on genetic and epigenetic levels. Radical surgery, as feasible, is recommended, followed by fractionated radiotherapy. And no standard role for pharmacotherapy has been defined. Thank you.